Good afternoon and welcome everyone. My name is Jody Jones-Turner. I'm a program manager with Mass General Kidney Transplant, and we're so happy you could join us this afternoon for a patient webinar on COVID-19 vaccine and kidney transplantation. We want to begin with just a few brief announcements. Today's webinar is being recorded and we will share it afterwards through YouTube. Thank you to everyone who submitted questions with your registration. We tallied over 100 questions and we hope to work many of them into our presentation today. If you think of additional questions, please use the Q&A message box on Zoom, and there will be time for a question and answer session after the speaker presentations. Finally, I'm pleased to introduce our three speakers. Today we have Dr. Leonardo Riella, the Medical Director of Mass General Kidney Transplant Program, Dr. Camille Cotton, who is the Clinical Director of Mass General's Infectious Disease Program, and Dr. Ayman Al-Jurdi, a Clinical and Research Fellow with Mass General's Renal Division. Welcome to all of our speakers and to Dr. Riella, who will lead off.
Thank you, Jody. Welcome, everyone. It is my pleasure to get started. And what we're going to do is give you some brief concepts about kidney transplantation and immune suppressive medications, and then dive into many of the questions that we have received about COVID and COVID vaccination. So to start, let me just give you a very brief overview of what happened this past year. So what I'm showing you here is the number of kidney transplants per month in the year of 2020 at Mass General. And as you can see here, we were doing about 10 to 15 transplants a month until about March, that with the COVID pandemic, we had stopped completely our living kidney transplant program, and also we reduced the number of deceased donor transplants that we perform. And this was, associated with, in part because of the increasing number of hospitalizations that we were having in the hospital and no beds available, and also a lot of the unknowns that the infection had brought into our practice. As after those 3-month periods, we can see that the number of kidney transplants started to increase again, and then it kind of leveled off afterwards, trying to compensate for that period. And again, this was just based on safety, and this was not only in our program, but all majority of programs in the country had this interruption. Despite that, I can tell you, that we had a very successful year. We transplanted 119 patients. We continued to have more patients being listed so they can get a deceased organ transplant. We performed 48 living donor transplants, and we had one of the best outcomes in the country. Not only that, there are a few things that we try to incorporate into our practice, starting with the virtual visits. I know many of you now have participated in virtual visits, and for a segment of our patients, this is a huge benefit. And we're going to continue doing that even in the absence of COVID, hopefully in the near future. We also extended our program to now having a MGH Hispanic transplant program that's going to be launched on the second semester of 2021. And this is being led by Dr. Cohen, one of our new transplant nephrologists. And also, we have been using some new forms of communication. I hope that most of you now have access to Patient Gateway. If you don't, please get access to it. We use the messaging system there to share information with you, as well as some of the other social media channels that you see here on the right side. In addition to all the clinical part that we do with our transplant patients, there's a huge research operation in the background. And I think, COVID has brought this even to life in terms of just recognizing the importance of that. So we have outcomes research. For example, we were involved in a number of different studies with COVID in trying to understand how COVID affected our kidney transplant patients. We also are involved in a number of studies developing new ways to better diagnose rejection, to better identify any damage to the kidney transplant, and also a number of different studies where we're looking at how new anti-rejection medications may better prevent rejection, and also minimize any of the side effects. And so, just to give you an idea, we have more than 130 individuals working exclusively on transplant research. And so that's in the background of all the clinical people that you guys may have connected with, from nurses to physicians to physician support personnel. And this also allow us to do research in very challenging areas, going from kidney disease recurrence, where we are part of a 38 transplant center worldwide consortium called the TANGO, where we perform some clinical trials looking at tolerance by doing a kidney combined with a bone marrow transplantation, and therefore do not require long-term immune suppression, to xenotransplantation, which is the transplant of genetically modified pigs' kidneys into humans that we hope to launch in the next year or two. And this will serve as a bridge for some of the patients that do not have living kidney transplant. And of course, this is part of a great multidisciplinary team that really kind of performs at an amazing level. And this past year has shown how important having all this team together makes in terms of our outcomes. So to kick off this specific patient webinar, I wanted to talk to you about why an organ transplant is rejected by the body, and share with you some very easy concepts that I hope will highlight and help you better understand some of the conversations that are coming next about COVID and COVID vaccination. So whenever we get a kidney transplant or any other organ transplants, with that organ, it comes a unique fingerprint. So these are unique proteins that are different from individuals. And these proteins that are mostly different between individuals are called human leukocyte antigens, or HLA. So because of this fingerprint, if you don't get a kidney from an identical twin, your immune system, which is basically our army that defends us against any potential external threat, may recognize that foreign protein as being a foreign body, or something that could put our body in danger. So our immune system, our army, will then recognize that foreign proteins and mount an immune response. And this immune response, if left uncontrolled, leads to rejection of the organ transplant. And we use anti-rejection medications to basically weaken the immune system. And there are two basically big branches of the immune system in which they protect us. So and these branches lead to two different forms of rejection. One is called the cellular rejection, and the other one is called the antibody-mediated rejection. And just to make it very simple, a cellular rejection is when immune cells go and attack your transplanted organ. And when we're talking about antibody-mediated rejection, it's actually weapons that our immune cells use. In this case, we can think about an antibody as a guided missile. So it's something that goes into the circulation until it finds its specific target. Once the guided missile finds its specific target, it triggers and attracts the immune cells to that specific site, okay? So the immune system, our army, has basically different weapons to fight whatever threat we may encounter. And most commonly are viruses and bacteria, and of course, in the case of an organ transplant, it may recognize those foreign proteins as being potential dangers. So using anti-rejection medications, we are weakening our immune system and preventing from our immune system to reject the transplanted organ. But of course, it will raise the risks of certain infections. And this is brings to Dr. Cotton. They're going to talk to us about COVID and vaccines for our kidney transplant recipients. Thank you, Dr. Cotton.
Great. Thanks so much, Leo. And thanks also to Jody for organizing this. So nice to see everyone there. I have met many of you over the years, and it's really a pleasure to be here today. So I'll be talking about COVID-19 and vaccines for both dialysis and kidney transplant recipients. Jody, do I have, there we, oh, great. So I'll be talking about disease overview and trends, also giving a vaccine overview, including recommendations, also discussing effectiveness and safety, and a little variant strains, And then specifically, we'll talk about COVID and organ transplant recipients, as well as vaccine efficacy, and then what transplant patients need to know in the current COVID environment. So as many of you know, we have had over 32 million cases in the United States. We've had almost 600,000 deaths. And you can see here in this slide, we still have a significant rate of disease throughout the country, although in many regions it's diminishing every day, which is great news. But we do anticipate that disease will be around for a long time to come. You can see here in this slide, we've had 3 major waves, sort of the initial wave last March and April, and then over the summer, and then this tremendous wave that we really felt as an entire country, and certainly felt in our region over the winter. And then fortunately, our numbers, specifically, I just picked one of the Boston area counties, but has really diminished over time. And you can see that our numbers are really falling, which is great. And we have, I think, over 40% vaccinated in Middlesex County. So that's really good news. Lots of progress on all fronts. We are seeing that more of the positives are in the younger age group now, which is probably because they're less well vaccinated and then potentially at higher risk for maybe engaging in more risky behaviors. So what about variant strains? We're getting a lot of questions about that, and there is a tremendous amount of work underway about variant strains. As you can see here, the B117 strain has really sort of taken over in the United States. This is what we knew would happen. There is a presence of the Brazilian strain or the P1 strain, and then the B1351 strain. And we're seeing this throughout much of the country. So this is as we know it now. There are many strains being sequenced, and we're really looking very hard at this situation because the concern is that we may have strains that are less susceptible or to which we are less well protected by the vaccine. We are doing a tremendous amount of work at Mass General and in the state of Massachusetts, and then by the CDC. And so this is sort of a work in progress, and we'll see what happens with variant strains over time. The more we control disease, the fewer variant strains we will see, which is a real reason to practice as much infection control and try to vaccinate as many people as possible. So I've been on the CDC Advisory Committee on Immunization Practice, and it's been interesting for me to watch the process. Overall, the steps are that first the vaccines are developed and the clinical research is done. And I have to say this year has been a real miracle for getting as many vaccines developed and the research done as quickly as we have, and protection in less than a year of the disease developing. So that's really, really impressive and amazing science. So after that first step, then the Food and Drug Administration either gives approval, or what's been done because of the public health emergency, they gave emergency use authorization. And soon for several of the vaccines that are out, they will, we anticipate that they will likely be giving full approval. After that step, then the Advisory Committee on Immunization Practice, which reports to the Center for Disease Control, deliberates and decides the appropriate clinical context or for whom we recommend the vaccine be given. And this was when we initially recommended that COVID vaccines be given to the elderly, and then various cohorts. What's been interesting is that the fourth step is that the states then implement what they think is the best vaccine plan. And that's where, as a country, we had a real variety of approaches. Florida did it very differently than Massachusetts and California, and that's why we are the United States, and that's how things are organized. But I don't think until we've had this public health emergency that we realized the differences in how things roll out. So it was helpful for me to understand this kind of algorithm. A good example of this right now is the Pfizer approval for children aged 12 to 15 is just between steps 2, where the FDA has approved use of the vaccine. And then we have our advisory committee on immunization practice tomorrow. And hopefully after that, if we recommend that it be used, then the states will quickly implement a vaccine plan. So there's been a lot of debate about vaccine delivery, and it has been done differently in different parts of the world. Just to go over the ethical principles that we have used sitting on this CDC committee, first is to maximize benefits and minimize harms. And that's where, in this context, we really aimed vaccines at the elderly, who, and especially people over the age of 75, in whom we were seeing devastating severe illness. We also have tried hard to mitigate health inequities and make sure that everyone has the opportunity to be as healthy as possible. Also to promote justice by treating affected groups, populations, and communities fairly, and try to eliminate barriers to vaccination. And then promote transparency, making decisions that are clear, understandable, and open for review. And I will say that for this CDC committee, all of our meetings are open to the public. And if anyone wants to live stream the meeting tomorrow, it's about 5 hours long. It's available through the CDC website. And it's a little, it's 5 hours, but so far there have been tens of thousands of people who tune in. So there really is transparency. So how are we doing with vaccinations? As of several days ago, almost 150 million people have had at least one dose, and over 100 million people are fully vaccinated. Truly impressive numbers. If we look at the population that's over the age of 18, that's close to 60% have had at least one dose. So these are amazing numbers. And hopefully with ongoing encouragement, we will encourage the rest of the population not yet vaccinated to be vaccinated as well. And the most recent CDC guidance is that, there's a lot of question about which vaccine is best. And there's a lot of discussion on Facebook and all of the, kind of in not really medical circles. But just to be clear, we do recommend on behalf of the CDC Advisory Committee on Immunization Practice that people are encouraged to receive the earliest vaccine available to them, and that use of all the COVID-19 vaccines are critical in controlling the pandemic. And this is how we have helped deliver vaccines. And until very recently, we didn't have really enough vaccines to pick and choose. So this is where this guidance was developed. And just to show a little bit of a comparison between the currently available vaccines, there's the 2 mRNA vaccines on the left, the Pfizer and the Moderna, which are, Pfizer's given 3 weeks apart, Moderna's given 1 month apart or 28 days. The dosing is a little different in that the formulations are different. They're not really entirely comparable, but the Pfizer is a 30 microgram dose and the Moderna is just over 3 times more at 100 micrograms. And then the Janssen vaccine, also called the J&J vaccine, is non-live viral particles, or yes, and this is a one-time dose. And I actually think that most of our transplant patients have not gotten the Janssen, but rather got the mRNA vaccine. These slides are all available on the CDC website. And I actually, as a sidebar, would say that any questions you have, try a Google search, and I would turn to the CDC for guidance, because this is where science and medicine happen. So if you're wondering, if you have questions, these are great websites for reference. So all currently authorized COVID-19 vaccines are recommended for people with underlying medical conditions, which would include immunocompromising conditions like organ transplant. And then, so what to expect after getting a COVID-19 vaccine? You can see here that there are many common side effects: pain, redness, swelling, fatigue, fevers. There's some tips on this website for how to make yourself feel better. And then there is this great app that if you wanted to report any potential side effects, we have accumulated amazing data through what's really sort of a crowdsourcing type of application. And we review this vSafe data, and it's a great way to submit if you have any unusual side effects, or of course, discuss with your either primary care doctor, another one of your medical clinicians, or your transplant team. I will say that overall, the current vaccines that are out there really protect quite well against pre-existing variants. So that has not been an issue. There was data published this week in the New England Journal that yet again, the vaccines protect quite well against variant strains. A big question is, how much do we alter, once someone is vaccinated, how much do we alter their ability to have vaccine in their respiratory system, in their nose, and then potentially transmit to others? And we think it does greatly reduce the risk of people having virus, but not bring it to zero. We have had a lot of questions about what's in COVID-19 vaccines, and just this is available through the FDA website, where if you actually Google what's in the Moderna COVID-19 vaccine, you can pull this up. It's pretty complicated and a lot of chemistry here, but overall, nothing of concern to me as somebody who works with vaccines. So there's been a lot of urban legend, but honestly, not so urban legend impressive from my perspective. There is a really interesting program that's worthwhile knowing about, which is in Massachusetts. We have this in-home vaccination program, which is for certain people who qualify who can't otherwise leave their home. And this is, there's this vaccination central intake line, and you can call if you have people, it's especially people who are homebound due to, inability to actually leave their home, or who haven't been able to make it to medical appointments. It does emphasize that temporarily homebound individuals are not eligible, but it's probably worth a call. Many of these people are getting the J&J vaccine because it's a lot easier, because there isn't the need for the deep freezer chain issues. So here's some modeling of what the impact will be on the overall number of cases, either through low vaccination rates as seen here in red, in black, and you can see that the less we vaccinate, and if we also, as shown in the not dashed, but the continuous line, which is the top one on the right in gray, if we don't vaccinate and don't use good infection control measures, we're still going to have a significant rate of cases. But the more infection control measures we do, which is called non-pharmaceutical interventions, which is really physical distancing and masking, the more vaccination, the more infection control we do, the quicker we put the kibosh on this pandemic. And this is the number of cases, right? And then that also was similar for hospitalizations and deaths. Now, what about COVID outcomes in solid organ transplant recipients? And also what about vaccine efficacy? So we participated in a national study looking at transplant patients across the United States. And what we looked at was for people who had organ transplants and who were hospitalized. Initially in the pandemic, we saw a really devastating and unfortunate hospital mortality rate of just over 20%. That was higher in people who were over the age of 65 or who had a history of congestive heart failure, chronic lung disease, or obesity. But in interesting data that we are reviewing and have submitted for publication, we're actually seeing almost a half the rate of mortality now compared to earlier in the pandemic. And that is wonderful news. We've gotten a lot better at diagnostics. We've gotten better at our treatment. And so now we're seeing just over 10% mortality rate. But what we're not seeing, the good news is that what we're not seeing is people who are home otherwise well, feel like, they either they're well or asymptomatic, or feel like they have a cold or a flu, but don't need to go to the hospital. So many of those people have done quite well. So this is not a 10%, 11% mortality rate in everyone with infection, just with people who end up in the hospital. And now I'd like to turn it over because we will hear about some homegrown research, which is really exciting. And we're so excited to hear about this, but really happy to have had people who participated in this work. So thanks to everyone for their hard work, both patients, families, and then our wonderful research team.
Thank you, Dr. Cotton. I'm going to be walking you through some of the data we know about COVID-19 vaccines, both in dialysis and in our transplant patients. So let's get started. Okay, and so I think it would be helpful before we dive into the information specifically about COVID-19 vaccines in dialysis and kidney transplant patients to just spend some time talking about vaccines in general in dialysis and kidney transplant patients. And so what do we know about the efficacy of vaccines in people who are on dialysis or who have organ transplants compared to healthy people? So what we know is that people who have organ transplants tend to respond less to vaccines compared to patients who are on dialysis or to healthy patients. And so this is a study from about 10 years ago where they compared people who had no disease at all, what we called healthy controls, people with kidney disease who are on hemodialysis, and people who had kidney disease and received a kidney transplant afterwards. And they compared the rates of an antibody response after receiving the influenza vaccine. And what they found was that in 90% of people who don't have any health problems, they were able to develop an antibody response, but only 57% of people on hemodialysis developed an antibody response, and even less, only 44% or less than half of transplant patients developed an antibody response. And so what we can conclude from this data is that people who have organ transplants tend to respond less to vaccines, not just compared to healthy people, but also compared to people with, for example, kidney disease before transplantation. Well, what about between different transplant people? Are they all the same? And the answer is no, because different people with organ transplants are different. And one of the reasons they're different is that how much medication that suppresses the immune system is different between different people. And so there was a study that looked at, similarly, looked at only transplant patients, but looked at how well they responded to the influenza H1N1 vaccine. And these people had different degrees of immunosuppression. And what the study found was that people who had lower degrees of immunosuppression responded much better to vaccination compared to people who were on higher doses of immunosuppression. And in this study, for example, only 8% of people who had high doses of immunosuppressant medications for their organ transplant And so what that tells us is that already transplant patients are sort of less likely to respond to vaccines in general, and that it really also depends on how much immune suppression you're on. So what about COVID-19 vaccine? What do we know about that specifically in our kidney and dialysis patients? And so Dr. Riella already went over this to some degree. And so just reviewing is that when we're looking at assessing the immune response to vaccines, we look at multiple things. And one of the things we look at is the antibody response, which is what a lot of the studies focus on. But there's definitely another part that we should think about, and that's the cellular response of the immune system, which is just a different part of the immune system. And another way to think about it is also how effective vaccines are in terms of looking at how many people still get COVID-19 despite vaccination. And so we're going to walk through all of those in our studies. So this first study looked at people who are on hemodialysis, so people with kidney disease on hemodialysis, but before transplantation, and looked at how well they responded to the Pfizer-BioNTech vaccine. So this study included 64 patients on hemodialysis and compared them to healthy controls. And what this study found was that patients who were on hemodialysis actually responded pretty well. So 86% of patients responded with an antibody response to the vaccine compared to 100% of healthy controls. And while this is a little bit less, this is still pretty reassuring. And another thing that the study found was that in dialysis patients who'd had COVID-19 before and got vaccinated after, that their levels of antibodies were much higher compared to people who did not have COVID-19 before and then received the vaccine. So it's almost sort of another booster for these patients. Well, what about transplant patients? So the data is very limited, actually, in terms of how transplant patients respond to the COVID vaccine. But there's a few studies out there. And so it seems that based on those few studies, that the transplant patients do tend to have a weaker response to the COVID-19 mRNA vaccines. So for example, when looking at just the antibody response, and we only have a few studies for this, after the first dose, the rate of response is only at somewhere between 2 to 15%, compared to 80% or somewhere around there for people who are healthy. And after the second dose, the studies have reported somewhere between 6% all the way to 54%, but the average is somewhere around 36, 35%. And so this is still much less compared to healthy controls. So we do know that from the limited data that we have, that transplant patients tend to respond much less compared to healthy controls. In terms of the cellular response to the vaccine, this is there's even less data on that, and so we don't have as much information. But transplant patients do still have some response, but after the second dose, only 2 studies have been done, and they've reported a range between 30 and 92%. So there's still some cellular response to the vaccine, but it's still less than the controls. And so when we're looking at studies, we can't just focus on the antibody response. We have to really look at both of these things. And but the bottom line here is that we really still need a lot more data before we can really tease out how much of an immune response do transplant patients have. And so this brings us to this. And one more thing is that in those studies which were done elsewhere, they were trying to understand, are there sort of characteristics in these different transplant patients that help us understand if someone is more or less likely to develop an immune response to the vaccine. And so in the limited data that we have, it seems that people who are older, who had their transplant more recently and who are on stronger immunosuppressant medications are less likely to develop antibodies after the COVID-19 vaccines, which is similar to a lot of our other information from prior vaccines that we just reviewed. Well, what about, this brings us to our study here at Mass General. So we performed a vaccine study here where we included kidney transplant patients who were more than 3 months after transplantation and had no active rejection. And we basically collected blood and urine samples prior to the dose of the first vaccine, prior to the dose of the second vaccine, and then at 2 months and 3 months afterwards. And we analyzed how safe and effective these vaccines are in our transplant patients. So we included 58 kidney transplant patients in our study, and this was done across Mass General and Brigham and Women's. The average age of patients that we included was 62 years old, and on average, people were about 4 years out from their kidney transplant. And the majority of patients were on 3 medications for their immune suppression, including tacrolimus or Prograf, mycophenolate, and prednisone. So first, looking at the safety data for our patients, what was most reassuring that we found that there was no serious adverse events in the study. So we did not have any patients who developed any serious allergic reactions. There were no episodes of rejection, and this was monitored by both the serum creatinine and some other blood tests for rejection called the donor-derived cell-free DNA, which is just a more precise way of sort of looking at how the kidney transplant is working. So that was very reassuring. And there were also no deaths in the study. So what we concluded based on this is that the COVID-19 vaccine was safe in kidney transplant patients. But what about how effective it was? Well, the first thing we looked at was how many patients developed an antibody response after the COVID-19 vaccine. And when we looked after the second dose of the vaccine, we found that only 35% of patients, or about a third of patients, developed an antibody response compared to 100% in healthy controls. And this is in keeping with some of the data from the other centers that we showed before, that transplant patients do have a reduced response to the antibody response to the vaccine. The second thing we looked at was something called neutralization. And what that means, it's one of the ways that antibodies work, which is that they basically form almost like a circle around the outside of the virus, and they prevent the virus from infecting the cells of people. And so, because while most antibodies may work this way, not all of them do. And so we wanted to see in our transplant patients who develop antibodies, are their antibodies able of sort of coating the virus and preventing it from doing that? And so what we found is that only about 2/3 of patients, of our kidney transplant patients, when they developed antibodies, they had this characteristic of being able to prevent the virus from binding into cells and entering cells, compared to 100% of patients in healthy controls who did not have any kidney disease. And so we're still actually, this is mostly the antibody data. We're still working on some of the cellular data. We don't have that yet ready to present for you. But another thing that's reassuring is that we looked at, in our patients, the risk of developing COVID-19 despite vaccination. And so thankfully, the overwhelming majority of patients in our study, 97%, did not develop COVID-19 during the 3 months of follow-up after the vaccination. So only 2 patients out of the 58, or 3%, developed COVID-19 during their follow-up. One of the patients actually only had a dry cough that she felt was similar to her seasonal allergies, but eventually decided to get tested and was found to have COVID-19. And her symptoms sort of improved spontaneously at home, and she did not require, to present to the hospital. One patient did develop COVID-19 that was bad enough that she required to be admitted to the hospital for some oxygen, but did not require an admission to the intensive care unit, and it was eventually discharged home without issues. So there were no, thankfully, there were only one person needed to go to the hospital, and no one needed to go to the ICU, and nobody died from COVID-19. And so the point we really wanted to make was just, while a lot of the studies just look at the antibody response in transplant patients, which, a lot of times looks disappointing, looking at some other things like the cellular response and how many people still develop COVID-19 despite vaccination, or severe COVID-19, like one requiring to go to the hospital, the degrees of how that changes, we think is really a much better, gives us a much better idea of how well people respond to the vaccines. And this is just our research team that I wanted to thank for helping us carry out this study. And I'll hand it back over to Dr. Cotton.
Great, thanks so much for presenting that data. So that's so cool that's cutting edge data and homegrown, which is great. So we are in a phase where across the board, we are seeing decreased vaccine effectiveness in organ transplant recipients. But what we don't know is, we definitely encourage vaccination. We don't want anyone to get the message that they shouldn't get vaccinated. I always say, and many of you have heard me say this in clinic and whatnot, that vaccines are kind of like wearing a seatbelt in the car. It's a really good idea. No promises. You still need to drive carefully. You still need to do all the right things, but some level of protection is very likely to be a lot better than none. So we do encourage vaccination for sure. And in the meantime, it's still the social distancing, masking, and hand hygiene that you've heard about again and again this year. So some of the key points that came out in March, for fully vaccinated people. So these key points came out, and I thought that they were good for people who have regular immune systems, but probably don't necessarily really apply to people who have altered immune systems, which is about 3 to 4% of the US population. So vaccinated doesn't always mean protected. And so a lot of these guidances that came out don't necessarily apply for safe post-transplant living, especially this avoid medium and large-sized in-person gatherings. And I think that along with continuing to be careful, medium and large-sized gatherings, just this week in Massachusetts, they're opening amusement parks at 50% capacity and whatnot. I would be very cautious about those things. And unfortunately, we're just not there yet for transplant patients. This is a really nice list from the Center for Disease Control on organizing large events and gatherings. but thinking about risk factors, you know, how many COVID-19 cases are in the community? What are the exposures during travel? What about the setting of the event, the length of the event, the number and crowding of people, and behavior of attendees at the event? So all these are really things to think about. And again, I would maintain significant caution for transplant patients. I do think that outdoors, socially distanced, masked, those are generally very, very safe events. We have had, so it's interesting, of all the things I didn't really expect, what we found at Mass General Brigham is that actually for indoor events, it was actually the most dangerous thing I could do would be to have lunch with my colleagues. So that's where we saw the most COVID transmission. So it wasn't in the COVID intensive care unit or in clinic or those type of settings. It was actually when we sat down and had lunch with our good friend and sat too close together. So I would encourage people to just be careful, especially when eating indoors. There was some really good guidance that came out on maximizing fit for cloth and medical procedure masks, and probably many of you have seen this already. But when there was masked on mask contact, and by that I mean both people are wearing a mask, that decreased transmission by about 95% when both parties were, at least in what they had done with aerosols and dummies doing research, had decreased by about 95%. And I'll show you some pictures of what that looks like. So there's the unknotted mask, and you can see there are gaps there. And then there's the double masking, which is the cloth mask over a medical procedure mask. And before I was vaccinated, this was what I liked to do, especially when I was out in public. And then there's this knotted or tucked medical procedure mask that you can see in picture C. And that one's good for certain face shapes. It really depends on the shape of your face. That one doesn't work too well for me, but definitely works for others. And this is a little bit of a confusing slide, but it actually compared unknotted medical procedure mask in the top versus double masking versus the knotted or tucked medical procedure mask. But what I want to emphasize is that when both parties in the dark blue are both wearing a mask, it really greatly decreases the potential for exposure, which is why it's really important to have both people masked. The gray bar is no masking at all. And then the other bars that are in between are when only one person's wearing a mask, because this just shows the importance of both parties being masked. We get a ton of questions about travel, and one of the topics I love talking about is travel after transplant. But unfortunately, before you consider traveling, one of the first questions the CDC recommends you consider is, are you someone in your household or someone you will be visiting at increased risk for getting very sick from COVID-19? So this likely applies to many transplant patients on the call, which for now we are recommending that you consider limiting your travel. And if you do travel, you want to think about what it would be like if you got sick in that destination. And that's something I always talk about. You know, will there be hospitals that could take care of you? Would you have family or friends that could help take care of you, etc.? So in conclusion, any currently available vaccine is good. Many of you have gotten the mRNA vaccine. At present, we're not even ready for full opening back up, and especially for transplant patients. For now, travel, both personal and professional, is not back to normal. Transplant patients are really less likely to be protected by vaccine, although some level of protection we always say is better than no vaccine for sure. And we do recommend that they consider cocooning themselves by having people around them all be vaccinated. And that's also one of the best ways to protect them. So for the future, we are considering booster vaccines for everyone potentially, but the big question that's out there is whether booster doses or alternative doses like double dosing for booster doses is possible. Right now, when the vaccines are under emergency use authorization, unfortunately, that is actually not possible to give booster doses. We are still waiting for everyone to get their first dose. There are some research projects underway that are not yet open. It's actually, I've been involved in this, and it's quite complicated to give booster doses under the current emergency use authorization. That may get a little easier when we have full FDA approval. And there is work going on in France where they decided that they would give a third dose to many transplant recipients even before the vast majority of the population was vaccinated, as well as Israel, where they are giving booster doses to transplant recipients. So we're hoping to have access to that information. And as soon as we possibly can, and as soon as we know it's a good idea, we would like to be able to provide better protection to transplant patients. But for now, we're definitely waiting on more information. So we're happy to open this up for the Q&A.
Thank you, Camille. This was great. We tried to answer some of the questions along the way, but I think there is this overall question coming from everyone about the antibody testing and why the CDC is not recommending and why many of the hospitals are not recommending. And just when we step back and look at the main studies that came out with both the Pfizer and the Moderna vaccine. So what were they measuring when they said the protection rate was 95%? Were they measuring antibodies, or were they actually measure the infection rate of vaccinated people? And can you clarify that? Because I think this is a major area of kind of confusion, I think, among everyone.
Yeah, so when they talk about 95% protection, that was in all people who were given the vaccine compared to placebo, so people who didn't get vaccine. And we saw that 95% of people were protected from having the infection. It's not about antibody testing in that population.
Great. And then, along the same lines, so it seems, what is there any benefit in antibody testing, and how people should be thinking about antibody response at this point?
That's a great question. So for now, we don't know so when Dr. Riella opened this webinar, he was talking about two types of immunity, and one is called cellular, and then the other kind is the antibody type. And so when we test antibody, we don't test the cellular immune response, and vice versa. So we don't actually have information as to what level of antibody response is protective against infection. So for now, we are not doing the testing because we think it might give you either a dangerous false sense of security because we don't know what level is truly protective, or it's possible that you could have a positive antibody test but still be vulnerable to disease. And so until we have more information, we are not recommending large-scale testing. And honestly, I'm dismayed that many people are like going online and ordering kits and doing all kinds of things. Often it's the wrong kit. And there are two types of antibody tests. One looks for whether or not you've had true disease or whether you had a vaccine response, and people are often ordering the wrong one. And there's also this new T-cell assay that's out there that's $150. It doesn't measure your vaccine response. I don't even know why they're selling it. It doesn't make sense to me other than to bluntly make money, because it looks for a cellular immune response if you had prior infection, but it does not. It says right on the website, it doesn't test whether you've had a response to vaccine. So I'd be cautious about doing all these things on your own, in that it's really hard to interpret. And I will tell you that even if I were a kidney transplant recipient, I would not be getting the tests because I really think it's giving people a false sense of security or false information. I can tell you that as soon as we really have good information as far as what the next steps are, You've all gotten a lot of messages from us, and we would love to be able to know the next best steps.
Camille, I really like the analogy that you do about the seatbelt, because I think, it kind of really tells us, where we are. So just to step back, and we were talking about, just in general, transplant patients that are at increased risk of infection. And I think, this is important for us to kind of realize that, unfortunately, because of all the anti-rejection medications that our patients take, they are going to be more susceptible. I think, the vaccine may protect against, either getting the infection or even some of the severe forms of the infection, which I think it's super important. And the issue about the antibody testing, to kind of reinforce what Dr. Cotton was mentioning, is that unfortunately the antibody testing does not predict necessarily that you are protected. So it gives you this false reassurance, and we want to make sure that our patients, even if they get vaccinated, that continue to exert some protective measures in terms of the wearing your mask, avoiding eating in places where a lot of other people are around that they don't know where they have been, and so forth. I know we're asking for a lot after like a very difficult past year, and hopefully as the numbers come down, a lot of these restrictions could be liberalized. So I think, we're not talking about this, for the rest of our lives, but I think what we're saying is that where we are right now, there's still a lot of infections going around. Depending on your region of the country, maybe even more or less. But I think we have to just apply all these precautions. And we've learned a lot about, certain things as eating habits and so forth. There are major areas where some of that transmission occurs. So I think this is really important. One of the aspects that were raised was about, what's the level of immune suppression that kind of creates this cutoffs of high, medium, and low immune suppression. And unfortunately, we don't have a very good thermometer of the immune system. We actually been working on the lab for quite a few years in saying, okay, can we have a number of saying, if you're getting too much or too little? And unfortunately, we don't have that. And for individual patients, the recommendations may change because the immunological risk, the risk of rejecting an organ, is not the same across two different donor-recipient pairs. So it may be that certain patients may have a higher risk of rejection. They require more immune suppression versus others that have lower immune suppression. I'll bring it on. Eamon, can you comment just on how some of these studies kind of broke down the level of immune suppression and how, like too simplistic that was?
Yeah, I think, for example, some of the studies looked at just big picture of like, are you on tacrolimus or are you not on tacrolimus, for example. But we know, for example, even on tacrolimus, there's people with varying levels where probably the response might be different. For the mycophenolate, for example, there's people who looked at if you're like on a high dose or very low dose. So there's like a lot of ways to look at it, but I think a lot of the studies sort of had a very simplistic approach of just, are you on this medicine versus this medicine? And I think while this gives us some information, I think there's a lot more nuance than just sort of the dose and the level, et cetera.
And just to give you an idea, when you first get the transplant, we usually have an induction therapy. We give you high doses of an antibody. We put you at the highest doses possible of the medication to prevent that rejection early on. As time passes, some patients don't have any rejection and the immune suppression is reduced. And what is the reduction depends on the size of the patient and depends on a lot of factors. So I think, this is again an area that unfortunately we should not be changing immune suppression just because we're getting vaccinated and we want to maximize the vaccine response. Because what we have seen in cases that has been reported in journals is that patients can reject the allograft if they reduce the dose of their immune suppression just by thinking that they can get their immune system to respond to the vaccine. But the cost of that at the end of losing a kidney is major, because once you have a very severe rejection, in some cases that's irreversible. So the risks are too high for us to be adjusting medication. I think the idea that Dr. Cotton brought up in terms of, okay, what are the next steps? and how can we maximize that protection. And as we get more information, more research that we are doing and other groups are doing, we can come up with strategies that may include extra boost dose or other vaccine to be complementary. But at least at this point, we recommend all our patients to get vaccinated, and we learn about the safety of that. And there are a couple of questions about it, and we know the vaccine is safe. There has been no reported, triggering a rejection, with exception of patients that had actually adjusted their immune suppression prior to getting the vaccine. And it gives this protection. How much protection, and this may vary, but I think it is a protection that we have to take into account based on the severity of risks of developed COVID infection just in general. So let me go through, let's see some of the other questions. There's a lot of questions just about, going back to, usual events in our lives. So a wedding and so forth, and how can you kind of maximize or minimize your chance of being exposed to the virus. And I think the masking is just such a huge one. And then of course, if you're gonna eat an event, I think you wanna make sure that you're not eating across from other people that you don't know. They're being very careful and so forth. So it's better, unfortunately, at this time to be more in isolation. And hopefully, this is something that in the future we're going to be able to adjust as the disease prevalence lowers. Camille, what else are you seeing as questions? I know there are quite a few.
Well, I think that's a great topic about like what can we do, and I do think that we should maximize now that it's spring and summer, and we should really work to be outdoors as much as possible. It's safer in general in that we know that indoors and crowded situations and that the aerosols and whatnot are higher risk indoors. So I would encourage people to be outdoors you can be with friends. It's a stats thing. The more friends you're with, the higher your risk of exposure. I personally would sit outdoors with friends, masked, somewhat distanced. As Leo said, I probably would avoid eating or removing my mask if possible, but I do think that that is fine. You could walk with friends, you could be out. I personally, until the pandemic really dies down, I'm not going to movie theaters or indoor venues. I actually really like eating outdoors at restaurants. I think it's great. We're kind of European now. It's like a free way to go to Europe, just, sit outside. But we really hope that all of you take our messaging to heart. I know it's a little discouraging, and I wish that we could say what your level of protection is. We are seeing breakthrough infections. That 95% still means that 1 in 20 people can get sick. And we think it's somewhat higher for transplant patients. And we wish we could give you a number, although for me, it sort of doesn't matter in some ways what that number is, because I just don't want to get COVID. So I would just encourage people to hang in there, be careful, be safe, take good care of yourselves, protect your families, people around you. Encourage people to get vaccine, because that's really the #1 way we're going to end this public health emergency.
So we're almost done with time. Camille, there are a few questions about people that work in schools, and is there any general recommendation about going back to work on that setting?
Yeah. So in some ways, schools are like a potential, medical setting. I do think it's wise. If I worked in a school and were a transplant patient, I would wear one of those double masks. We are seeing a real decrease in disease in the community. And then hopefully this week, the population that's 12 to 15 will get vaccinated. Maybe more younger kids will get vaccinated over the summer as disease drifts down. Hopefully more people, fewer people will be exposed and be at risk. But double masking, hand hygiene, a little social distancing, and we've had a pretty amazing school experience overall with very low rates of disease transmission within schools.
Great. And maybe I'll add just answer one of the other questions. There are a lot of questions about belatacept, which is just one type of immune suppression. And the question is, does it affect, the vaccine response? And like the other immune suppressive drugs, it does. And of course, we're learning more and more about, how much it does and how does it compare to some of the other medications. And I think we cannot be for sure certain, because ultimately what we want to know if the vaccine is protecting against infection. We don't want to know if, it generates X percentage of antibodies, but is it really kind of protects from especially the severe infections that are the ones we're most worried about. And I think we will be getting more data on that very soon. May I pass to Jody? Since I think we're on time, we'll try to answer some of the other questions offline. And thank you so much, Dr. Cotton, who is this major leader that this past year has been working with our transplant program and leading not only our hospital but also nationally with the CDC. And it's great to have you on board, and we really honor and grateful for all the dedication you have to our program. To Dr. Aljurdi for joining us and helping with this amazing research, and Jody for coordinating this patient webinar.
Of course, thanks, Leo. And to echo Leo's point, yes, thank you to all of our speakers today, and also to everyone who joined us for this webinar. We're thrilled. One of the highlights of the pandemic is that we have this ability now to communicate more easily through webinars, and so we plan to continue hosting them in the future. And we invite everyone to join us in June for our next topic, which will be a patient webinar on the new kidney allocation system, and some information on strategies for pursuing a living donor if you are looking for one. So that will be planned for Tuesday, June 15th, also in the afternoon at 4 o'clock. We'll be sharing additional details about that through Patient Gateway. And Patient Gateway is really becoming our way to communicate with patients. So hopefully all of you have accounts that are active, but that's going to be a really important way to get the latest and greatest information from the Transplant Center. So stay tuned there. And then we also want to mention, we'll be sharing this webinar, which was recorded today, through our Mass General social media channels. We have channels on all the major platforms: Twitter, Facebook, Instagram, and LinkedIn. So please follow us there if you haven't already, and that's another way to stay connected to the Transplant Center. So thank you for joining us today, and we hope to see you again soon. Be well.